Good morning. Good morning. Thank you for joining us this morning. My name is Dr. Nadia Richardson, and I'm very excited to welcome you back for the 2021 National Minority Quality Forum Leadership Summit on Health Disparities and Spring Health Braintrust. I will be moderating this morning's session, which is titled Using Advancement in Healthcare Policy and Technology to Improve Maternal Mortality. We have leading voices on this issue with us this morning, and so we're excited to have them share with us recent technological and policy advancements around helping maternal mortality rates. So what I'd like to do is jump right on into this conversation and welcome our panelists for this morning. We'll start with Deanne Millison, who is the Deputy Policy Director with the Office of the Vice President of the United States. Good morning. Thank you for joining us. We also have with us Dr. Nikole Benders-Hadi, who is the Medical Director of Behavioral Health with Doctor on Demand. Thank you very much for joining us. We have Ms. Veronica Adamson, who is the General Care Solutions Leader with Obstetrics Monitoring with Philips. Thank you for joining us. And finally, we have Dr. Rachel Villanueva, who is the President-elect for the National Medical Association and also serves as the Clinical Assistant Professor of Obstetrics and Gynecology with the NYU Grossman School of Medicine. Thank you very much. I myself, again, am Dr. Nadia Richardson. I am a professor of bioethics, a proud 2018 Leader of Health Award recipient from the National Minority Quality Forum, and I'm the founder of No More Martyrs Mental Health Awareness Campaign. Very excited to be a part of this conversation today. If you are joining us, please be mindful. We want this to be as interactive as possible. There is a question and answer box where you'll be able to post questions to the panelists. That box will be monitored throughout this conversation. Please make sure that you post your questions to that box and not necessarily to the general chat box, because the question and answer box is what will be monitored during the discussion. So let's go ahead and jump in. We will start with you, Rachel. And we'll start with the first question of the day. I know she's like, wait, I'm going to be put on the spot first thing in the morning. We've got you muted.
I'm always rustling, so I'm always muting myself to make sure I'm not rustling on the webinar. But I'm used to always being the last one with my last name being V. So thank you. Thank you for putting me first this morning.
Yes, we're going to make you first this time. We'll start with this first question. How has telemedicine been utilized by practitioners during the pandemic, and can this be a tool that improves Black maternal health outcomes?
Yes, that's a great question. Obviously, the pandemic over this past year has forced us as physicians and healthcare providers to be more innovative and think outside of the box and use different tools to take care of patients and keep in contact with our patients. And telemedicine served that purpose very well for us. Our American College of OBGYN recommended using telemedicine to take care of patients. We were able to monitor obstetrics patients that way, monitor babies and moms and keep them healthy through pregnancies, through their pregnancy, through the use of telemedicine. It expanded exponentially for us. The fact that reimbursements, insurance companies were allowing reimbursement for telehealth services was also very helpful to keep physicians afloat. But much the same way that we saw with remote learning for children in schools, there were definitely barriers to being able to use the technology fully for some individuals. And obviously, we see that these things end up falling down racial and ethnic lines. So there were disparities to just even having the technology itself, having the ability to have a computer or a smartphone to access a televisit with your doctor, the ability to have high-speed internet, being literate enough to understand how to navigate a portal or a website. So all of these things continue to highlight disparities that we need to address as healthcare providers. And so I think opportunities like today are perfect and important for us to continue to be able to expand technology as a means to be able to reach patients, not only through the pandemic now, but beyond, especially in rural communities and in urban communities that lack access.
Thank you. Deanne, what are some of the White House's plans and initiatives to work on mortality and maternal mortality rates?
Yep. Thank you for the question, and thank you for inviting me here. I think the best place to start, I had the good fortune of working for the vice president in her Senate office, and that's where her work on this issue began, where she introduced several pieces of legislation to address maternal mortality, specifically as it impacts African American women. And the same is true for the president, who has a long-standing history fighting for the Affordable Care Act and improving Medicaid, all of which kind of help improve maternal outcomes. So once the administration got into office, they carried that work on into this administration. And I think I want to highlight kind of 4 initiatives. The first place I would start is the proclamation. The week of April 11th through April 17th, the president issued a proclamation identifying that as Black Maternal Care Week, and just really signaled the importance of maternal health care, Black maternal health care to this administration, and signaled a focus on trying to address the issue. And I think combined with that proclamation, the executive order on racial equity and the executive order establishing the Gender Policy Council just kind of set the stage for a kind of whole of government approach where these entities were going to take a real serious look at the maternal mortality crisis, and specifically as it impacts African American women, and I should mention, and as it impacts Native women, in addressing it in that way. The second thing I would want to highlight is included in the discretionary budget, the administration invests $200 million to address maternal mortality. This includes $30 million to address implicit bias training programs and developing state home programs that have like the kind of wraparound services that we see improve health outcomes. It also includes funding for maternal mortality review committees, which give us the data and the studies and answer the questions after in instances where there are complications in maternal mortality and morbidity. We get more information on how to do it better. And there's significant funding for rural communities and rural strategies to address this issue. There's been studies that show that rural communities have a 9% higher probability of maternal mortality and severe morbidity. So there is a focus of funding there. The third thing I would want to highlight is just, so I would say that funding and those programs kind of directly address the issue. I would say the third bucket is it's a bit broader, but just a general increase in funding in HHS civil rights programming and funding for Title 10. And there's a $6 billion funding for the Special Supplemental Nutritional Program in WIC. And all of those things are, combined, have been shown to improve maternal outcomes. And the last thing I would say is most recently, the administration approved Illinois' 1115 waiver, which extends postpartum coverage on Medicaid for women on Medicaid from 60 days to 12 months, which we think will just have a huge impact in maternal outcomes for women on Medicaid. And Illinois is the first state to do that. And there are provisions in ARP to make that process easier for other states. So I think those are the major components, the major pieces thus far that this administration has done to try to really tackle this issue.
It's certainly promising and exciting to hear so many fantastic things coming out of the White House that focus on this particular issue. I do have a quick question about the trainings that you mentioned in regards to implicit bias, because I know just as in my field, I've taught with schools of medicine. I'm currently in the biomedical sciences program. I've taught with schools of public health. Sometimes implicit bias can be interpreted in so many different ways, and oftentimes it's often offered as an elective rather than being embedded into the required curriculum for these students to graduate and go on into the field. So when you're talking about the implicit bias trainings that are going to be or curriculum that's going to be supported through the White House, how do you envision that? Is it going to be embedded in curriculum? Is it going to be trainings that are offered to individuals who are already in practice?
I think we imagine it being a bit of all of the above. I know we would defer to the research, defer to the experts, defer to the people that do this training. We want it to be implemented in the way that it's the most effective.
Mhm.
And I think we would look at areas, we would look at schools, we would look at institutions and organizations that have done it successfully. But I think when thinking about it, just in other contexts, not only do you want to see the training in school, I'm a lawyer by training. We do our continuing education. That it's something that you continuously want to learn. So I think the format that is the most effective and makes it the most widely available for those who need it and for those who want it, for those who may not even know they need it, like that is how we would want to implement it.
Okay. Fantastic,
If I
fantastic.
could just chime in for one
Yes,
second.
please.
I would just say a lot of the medical schools are embedding it into their curriculum now, which is really the way it's going to be effective. I think we all know that when it's a 1 hour training, it makes it sort of difficult.
Mhm.
Obviously, we need to attack this broadly, so we have to do whatever we can do. And so obviously attendings that are already out of school, those trainings are important. And I think it's important that it's ongoing. I think it's important that hospitals and healthcare systems make sure that people understand this isn't a one-shot deal, that it's a continuing education, right? It's part of your process of continuing to be a better healthcare provider and to understanding the communities that you're serving. But it's, in my medical school, it's definitely part of, it's being embedded really in everything from the very beginning, even in the basic sciences. So not even just the clinical aspect, but right from the beginning, which I think is so important.
That's
Very.
And I would even add, I think that's really interesting what you're saying, Rachel. And I think even in technology, right, making sure that that training is also present for people developing, the software and the devices and everything else in the background. I mean, that's come to the forefront a lot recently, but making sure that it's the broader, ecosystem as well and the tools that we have.
Absolutely, absolutely. And Veronica, why don't we just go right to you for the next question? What role do large health technology organizations play in addressing maternal mortality?
Yeah, that's a great question, Nadia. And maybe before I answer, I just want to say thank you for having me. And it's really fantastic to be among such a passionate team of experts driving change here. I mean, for me, the large companies, it's a lot about the ecosystem that we play in, right? It's, you could say we lead, LEAD, in the sense that we want to support across the ecosystem. So L in terms of legislate. So one of the things that I think we can do to have impact is to use the influence and sort of the knowledge that we've gained along the way to support things like Momnibus, right? And also to spend time with legislators when they have questions on how technology can support what they're trying to do. So we spend time often with state legislators or different people in the field helping understand what technology can do to help them with what they're trying to do. The second is empower. So beyond just providing obviously the actual tools for for clinicians who are really transforming care, it's also creating awareness of the broader range of solutions. For example, startups or data gathering companies, or the way that change management is important in ensuring that the legislation, for example, actually has the impact that it needs to have. advocating. So advocating, for the voices of women. I think this is a space where often there isn't as much, attention paid in a sense, especially in healthcare, and you see that it's often called a niche category, or, it has historically received less funding. So really speaking about not just the human side of it, but also the financial impact, right? What can you save? How can you benefit from the space? And last, I think, is probably simplest is donate. So for example, we've donated, ultrasounds to some of the, community clinics and things like that, just to make sure that, when we can, that we're also sort of directly contributing to the change. So I don't know if that answers your question, but those are some of the areas that we are focused on.
Absolutely, absolutely. Can you go into a little bit more detail about the Momnibus Act that you mentioned? No More Martyrs is a mental health awareness campaign, again, that seeks to build a community of support for Black women and girls. We're a national organization, but founded and headquartered in Birmingham, Alabama, which is where I'm joining you from today. And so I'm excited to share that Congresswoman Terry Sewell has been a part of pushing that act forward and has been very vocal about it here in the state and, of course, around the country. Can you go into a little bit more detail about that act?
Yeah, I certainly can, but we have Deanne here, and I'm sure she would do a much better job than I would. But I can say that I think it's a super exciting initiative, and it's really, I think, first of a kind, and especially the visibility that it's had in driving some of the underlying enablers as well of the change. So I'll pass it over to Deanne, because I really think she'd do a better job than I would on that.
I will talk briefly about it. I will say the beauty of the Momnibus, I remember being in the Senate kind of working on this, was it was a comprehensive approach. There was a lot of little pieces, bills, there was a bunch of congressional leaders, and this was kind of the first bill that was trying to tackle all of the issues from all of the angles. So the goal was to, one of the things that we really liked about it was making investments in the social determinants of health, like housing, transportation, nutrition, and the idea that those things may affect maternal mortality and morbidity well before you get pregnant, well before you're in labor, and well before you're postpartum. I would say the other, key pieces to it, I mentioned some of the things, the maternal mortality review committees, the support for people with mental health and substance abuse and disabilities and things like that. There's a focus on data collection, which, as we were doing this work, realize that we don't have great data, and you need good data, you need quality data to really come up with the solutions. And as we said, there's an investment in telemedicine, and that has become all the more important during the pandemic as we learn. So I think that's the beauty of the Momnibus, was this kind of comprehensive, well-rounded approach to addressing not just funding when you are in labor, but funding like the whole person to improve these outcomes.
Yeah, I would agree. And I think one of the really powerful things, right, is for example, the data aspect. So we think we know, where the problems are, right? But until we actually have the data to look at that objectively, and then also to, once we put in place initiatives, to go back and look, were they successful in changing, what we wanted to change? It's historically been very difficult to do that. I think that's one of the most exciting things, Dan, that you mentioned. And of course, I'm partial to the digital side of it. There's an aspect in there around how can digital solutions help, and they're just one area. But I think that this is an area that really could benefit from all of the technology advances that have been made in healthcare and haven't yet been applied in the space.
Deanne and Veronica, thank you so much for bringing up the Momnibus Act. I couldn't agree more with all of your comments. I think the comprehensive aspect of the act is what's making it so very well received, and also just to highlight again the importance of whole person health. Right, when you're talking about mental health care needs, physical healthcare needs. There's so much overlap. It really highlights the need for truly integrated care, and having support through this act is just really something that was really great for us at Dr. Demand to be able to see as well.
Absolutely. Nikole, let's come to you with a mental health question. What are the prenatal and postpartum mental health challenges that mothers are facing, and how has COVID changed that experience?
Sure. Yeah. Thanks, Nadia. And I'll say too, so happy and proud to be a part of this panel. Women's mental health issues has been something I've been passionate about for a very long time now. There are many mental health challenges I think women in particular face, especially in the pre and postnatal periods, just because it's a time of so much change, right? Think about all the physical changes, the hormonal changes, emotional changes, adapting to the weight and responsibility of bringing new life into the world, right? So we already see, exacerbations in things like depression and anxiety during the perinatal period. So reproductive psychiatrists in particular spend a lot of time educating about what is to be expected and how moms can surround themselves with additional support to really just take better care of themselves and their babies. Why is that important though, right? It's really because there's unfortunately some inconsistency in how often healthcare providers are really asking about mental health symptoms. There was one study published by the CDC that showed that only 1 in 5 women reported that their healthcare provider asked them about symptoms of depression in the prenatal period. In the postnatal period, that was 1 in 8 women. And that's despite an average of about 13% of those same women actually experiencing those symptoms of depression. So I think we can do a lot better. I think that screening programs and asking about symptoms of depression in this population is so important. There's so many different ways that can impact women: postpartum depression, adjustment disorders, the normal adjustment with baby blues, right? There's a lot of ways that mood changes can impact the maternal population. So we just have to get a lot better, I think, at screening for it. With COVID, we see that women have higher infection rates. There's also, the social changes that are impacting women more. Things like closures of daycare centers, right? The fact that, it's mothers who often have caretaker responsibilities and adjusting to virtual learning with older children, often all while you're trying to juggle work at the same time. There's also, the very clear structural inequities that are disproportionately impacting women of color. So we could talk about things like, unequal access to vaccines and vaccine hesitancy. So all of that really means that minority women in particular are more impacted because of the pandemic. So we're seeing more depression, more anxiety, more trauma, but without the kind of resources needed to really adequately support them. So again, that's why I think this attention on technology and policy change and how we can better support women with their mental health needs in particular becomes so important to be talking about right now.
I really appreciate the way you mentioned earlier about the whole body health, like the whole person health. And some of the advocacy that we've been able to do during COVID, we're seeing a lot related to misogynoir, right? The experiences of Black women, specifically having to manage racism and sexism. But we're also seeing that during COVID, with so much isolation, social isolation and social distancing, where you can't tap into your networks and supports in the same ways. But what we're hearing from Black mothers is they might be pregnant, they may have given birth during this time, and they're doing it during a very difficult racial climate where there's been police shooting, videos. There have been, the trial that, of course, that just ended. A lot of things that have happened over the course of this time, hand in hand with COVID. When you're thinking about the whole person health and being able to support women, especially pregnant women, and particularly Black women during this time, what are some supports that you would offer them? And then how can we as researchers, elected officials, policy individuals who are working in these different types of spaces of technology, policy, education, and health, what are some things that we need to be mindful of in creating spaces that support Black women in their maternal health at this time?
Mm-hmm. It's a great question, and I think in terms of, the actual resources, right? I think it comes down to improving access to care and continuing our work in breaking down stigma so that women are actually, engaging in the kind of care that's needed, right? There's so many different factors, some of which you just mentioned, right, that are impacting, minority women, women of color. When we talk about, words like strength and resiliency, right, that, are sort of falsely implying that, we're able to handle this burden better than some other groups, right? I think that, sort of falsely perpetuates this same idea. But using technology and telehealth, right, to improve access to really healthcare providers that look like me, right, that look like you, because we know that when you're accessing care from a provider that looks like you, you're going to have better clinical outcomes, right? That's very well proven. So continuing to break down those top barriers. Stigma is only one. I think being able to access care, from the comfort of your own home and the privacy of your own home has a lot to do with that, the stigma challenge as well. And just continuing to have these kinds of open dialogues as well, right? Just to make it known the prevalence of these types of issues, right? That you're not alone and that there are resources and help out there for you.
Can I just piggyback off of that? The vice president hosted during Black Maternal Care Week a roundtable with Ambassador Susan Rice, where 4 women shared their stories about their stories about their own maternal mortality and loss, and everything that Nikole said was correct. I mean, just the need to share the stories, the common refrain of asking questions and speaking up and not being believed or not being taken seriously or being dismissed. And it was everyone almost shared the same thing, even though their losses were different and profound in their own ways. And I think the common thing we learned there was just the importance of doing that, of telling those stories. And the VP just really emphasized the courage that these women had and the importance of doing it and the need for the community to still do it, to share their stories, and for the healthcare community to listen. And I just wanted to share that, to echo that sentiment, because the VP and Ambassador Rice really brought that to life and to the forefront at the White House recently.
And
Thank you.
I'll just add in if I can. I think what I've seen just as a practicing doctor is really Black women doing what Black women do, and which is to rally around our sisters and fellow women to address the issues that are affecting us. And so it's not that Black women are just kind of like allowing themselves to remain these like terrible statistics. So either it's support groups, having access to doulas, talking about lived experiences so that women can understand and really kind of appreciate what they should be thinking about when they go seek healthcare and they seek care for their pregnancy. And also just being able to seek healthcare providers that look like them. And I can definitely say that really over the past, I would say the past 2 years, I've seen really an exponential jump in the number of Black women that I see in my practice. I think, and very often women come in talking about not feeling appreciated, not feeling understood by other physicians, coming for second opinions because they didn't quite trust what was told to them. So I think that, at all different levels, we're addressing this issue, but I think we ourselves as women and consumers of healthcare are really driving what we're seeking and how we want to be treated in this space.
Well, Rachel, let me ask you this question. As the incoming president of the National Medical Association, how do you plan to work to tackle the issue of maternal mortality?
Yeah, well, that's just simple question. No, no, that's a great question. I think for me, it's really important. Obviously, I'm an OBGYN, so women's health issues and issues of maternal mortality are really so important to me. And for me, women's health in women in general will be a very important part of my presidency. And that's not only taking care of our patients, but actually taking care of ourselves as well, and working towards dealing with issues of harassment and bias in the workplace for us, for career advancement, for simple things for us as just even being able to have proper maternity leave. I mean, I can't even tell you how many colleagues, are off for a month and really get a lot of pushback from their practices or when they're residents for even just taking off that time for care. I think, obviously dealing with this issue is very similar to the Omnibus Act. It needs to be comprehensive. It's such a complex issue. And I think trying to address it at all different levels. I will definitely say we have a very large scientific section in the NMA, that's the OBGYN section. We also have a women's health section as well, but particularly the OBGYN section, has been dealing with this issue for a very long time. 2019 convened a multidisciplinary group. It was like a call to action, which included all different kind of healthcare professionals to specifically deal with the issues of decreasing maternal mortality. So I think, dealing with the specific recommendations that came out of that summit will be very important as I move forward, and just dealing with awareness, making sure we collaborate. I think the pandemic, one of the great things that I saw coming out of the pandemic was collaborations along different groups, minority groups, majority groups, all working towards the same goals. And I think very often, especially in medicine, we work in silos. And I think the pandemic forced us to really kind of collaborate more. So that's really, I'll really be working towards making sure that we continue to partner with other groups for this issue. We're really looking at diversifying clinical trials to get that all important data that we need, working with legislators to push forth things that will improve access, will improve training, exactly as what Deanne was talking about, all the things that we need to really address this issue. It's so layered, but really, I really look forward to a really productive year. I'll be calling on each of you, so I'm glad we're on first name basis already after 45 minutes. So, but yeah, I'm really looking forward to a really exciting year as president.
Rachel, I'm glad to hear you talk about that. And I absolutely agree. But the collaboration, the integrated care models, that is so important. I think for myself, really thinking about the pandemic and all of the loss and negativity that has come from the last year, I try to reframe that, right, and think about the positive things that have come from the pandemic here. I think that the data, right, is a really important piece, that we have so much research that is going into the impact of COVID-19, the different populations and how it's impacting those populations differently. But also, I think it's created a lot of space for technological advancements, right? Improving access to virtual care and telehealth services. There was also a study that showed that 3 out of 4 Americans now consider their mental health as important as their physical health, right? That's a huge change, a huge shift in thinking. And, again, it's something that I think we can take away from 2020 and really lean into as we're thinking about how we improve healthcare generally.
Yeah, Nikole, I just want to echo that. I think it's really amazing what this has done on the tech innovation side. So it's really opened up a lot of opportunities, for innovation. So just to give you an example, we had this concept at Philips that, we should bring the care to where the mom is at, right? And protect the clinicians and the moms when they're in the hospital with COVID, give them more space, sort of reduce the number of sort of non-necessary interactions so they could really focus on the mom. In the past, that would have taken us maybe 3 years to get a product out into the market. And With COVID, we were able to go to the FDA in a couple of weeks and say, hey, this is really going to make a difference for moms. Can we work to make this happen? And it was possible. And to me, that was, as a twice high risk mom myself, something that I just felt so moved by, that we were coming together across, private, public, legislation, everybody, to make the changes happen. So totally agree with you.
What I really appreciate about the direction that this panel is going is I'm seeing that we're going to do some work together and that we're going to stay connected. And that kind of collaboration is what's so necessary and needed to bring about the changes that we're discussing today. Veronica, what kind of supports does technology need? What kind of partners and collaborations does technology need to drive change in this particular area?
Yeah, that's such a great question. And I think one thing I'll caveat is, obviously I'm coming from a technology angle, but technology is really an enabler, right? It's an enabler of the clinicians, and there's still a lot of challenges with technology, right? Actually putting it into practice, making sure that it isn't biased itself. But I would say, there are three areas where I see technology really being powerful, and we need partnerships, across the three. So the first is really empowering moms to be in the driver's seat of their own care, right? I think, again, as a high risk mom myself, you often know something is wrong, but you don't always know where to go with it, or you don't necessarily feel heard, right? So providing through digital platforms, communities where moms can go and choose who they want to get advice from and feel comfortable with the advice they get, to have tools that they can use on their own, like kick counters or nutrition apps, to actually, take control. I think that's one, and that takes an ecosystem, right? I'm sure you guys have heard of Wanda Irving and the tragic story of the loss of her daughter, who was one of these examples of someone who knew something was wrong, right? But unfortunately, wasn't heard. And I think the community is one of the areas that she's highlighted as would have been a key asset, a digital community for her daughter. And I think, we, as Philips, of course, we have, pregnancy apps like many other companies, but I think it's really partnerships around those different communities and the different solutions to bring that to the forefront is one area of partnership. I think another key area is what's been mentioned already around remote monitoring, right? So bringing care where the mom is at. Right now, if a mom is at risk or high risk, she needs to go in for fetal non-stress tests, could be 20, could be 40 times, right, during a pregnancy. And if you think about what that means for her, right, getting on public transportation potentially for, maybe even a couple hours in the middle of the summer, in a pandemic, going into an environment full of sick people, paying for childcare, missing work. I mean, it's impossible, right? And no mom is going to be compliant. I know I wasn't, right? And it's not like I was at risk of losing my job. So I think partnerships to enable, clinicians to be able to provide care where the mom is at, because I think clinicians want to do that, right? But it's multifaceted. There's, there's concerns around, what happens if something goes wrong. The technology itself is there, but not necessarily established. The reimbursement needs to be there because OBGYNs often, have trouble staying afloat, right? So we can't underestimate the need for reimbursement. So in that case, I think it's really an ecosystem across pretty much every player. And the last thing I would say is, an area of technology that I think we haven't necessarily leveraged enough is AI, right? So again, if we go back to, Wanda Irving's tragic experience with her daughter, right? The outcomes or the adverse outcomes of having a baby, right, can often be detected by technology, right? That's something that's in practice in other spaces of the hospital, right? Early warning scores or, identification of hemorrhage or hypertensive crisis. Those are things that technology can help with, but we're not there yet, right? They're not really in practice yet. They can still be biased, but I think that they're working with the big tech companies, working with clinicians, working with, the ecosystem of players out there to get that right, I think could have a very direct impact. And I'll just make one more point, because you can tell I could probably go on for days on this, is working with other countries too. So, Denmark, for example, has put in place fetal non-stress tests, broadly speaking, for moms at home. We could learn from them, right? Similarly in Australia. So I think there's also this international aspect. We have the worst maternal mortality outcomes of any developed country, right? So what is it that other countries are doing that we're not? I think that's also a key area of partnership.
Absolutely. Absolutely. As a first generation American, I absolutely appreciate looking at what other countries are doing and learning and value, and then collaboration, even in that sense, right?
Yeah.
Being able to have them come and have us go and learn from each other and support each other in the work that we're doing. So we actually have a Q&A box that's lighting up a bit. So I think, and I'm happy to see that. I'm happy to see that there's audience members, participants that are ready to jump into some conversation. So I'd like to go to some of the questions that have been posted. One question: according to a report in Pediatrics Journal, roughly 3 million children in the United States are being raised by their grandparents. Roughly 55% of Medicaid beneficiaries are female. Are there policy efforts to support healthcare access to older Black seniors?
I can take this one. Yeah, Veronica, you just mentioned, Juan Irving's story, right? Which I think is certainly relevant here as well. There's a couple of policy changes, acts that I'm thinking of: the Connect for Health Act and the Telehealth Modernization Act that are aimed particularly at improving access to care for this population. At Dr. Deanne, we have been moving into the Medicare space in the last year. I think we've seen tremendous demand for telehealth visits, for therapy visits in particular. And one of the subpopulations we see the most growth in is the 65 plus age group. So being able to improve access to care for populations like grandmothers, right? And Medicare coverage as well, particularly. What those acts do is specifically to remove the geographic barriers and allow the home to be used as the originating site for Medicare Part B, which allows for telehealth services, right? So I think that those are a couple of policy changes, acts that are so important for this population and allow, the maternal needs of moms who are now grandmas raising their children, their grandchildren, to access care no matter where they live.
And just to add to that, something that is front of mind in the president's American Jobs Plan, this administration is committed to investing $100 billion in broadband. And when the vice president talks about it, she talks about it affecting, obviously, we know students and their virtual learning that we've seen this year. She talks about it affecting small businesses, and she talks about it in the telehealth context and seniors getting access to healthcare in rural communities and during times of the pandemic, and just any instance when they can't, as you were mentioning, I know that wasn't specific to seniors, but just the burden of traveling back and forth, long distances, public transportation, et cetera, et cetera. So although we may not think of it necessarily always as closely related, that when the vice president thinks about the issue, thinks about broadband, it's that telehealth to seniors, it's healthcare access for that population that is front of mind as well.
Also in very rural parts of the country, right? So again, I'm in Birmingham, Alabama, but when the World Health Organization came here a few years back, they traveled to other parts of the state, particularly the Black Belt, and referred to those areas as having third world conditions. And having done some advocacy and training down there, some of the main issues is that there is a lengthy ride to a hospital, right? Or very few practicing physicians in smaller towns, so they're having to travel to larger cities to be seen. So, but then telemedicine in those areas, because of access to broadband, access to those types of things, is also very limited. So we end up working with nonprofit organizations or churches or different things like that to kind of get that work done in those areas.
Nadia, can I just add?
Yes.
I completely agree. Just to, to add on your point, 50% of women, right, live in counties without an OBGYN in the US.
Yes.
It's dramatic. And in addition to the internet, right, it's also the electric plugs in certain homes are not safe, can't be used with certain devices. So, I mean, it is such a multifaceted problem. But again, I think that we have to start somewhere, right? And I think we need to start doing something. And for some of those communities, for example, beyond all of the wonderful things with, broader healthcare, I think technology could help us, but it is going to be difficult, especially in those places.
Absolutely. So another question that was posted actually speaks directly to technology. It said, technology as an enabling tool is a very powerful concept. Is there a defined, prioritized agenda being articulated and advocated for moms in regards to technology?
Yeah, I think this whole panel was just kind of spoke to the fact that we understand and are advocating in different ways, right? Veronica's advocating from her aspect. I'm advocating as a clinician dealing with moms. I think Deanne's dealing with it from the policy issue. I think we obviously realize that there's a need to expand this technology, particularly for communities that lack access, urban and rural. And I think it is going to take us working in all of these different spaces. I mean, definitely as a clinician, the ability to be able to access patients in times of a pandemic or when they're unable to come to the office is really crucial to continuity of care and to continued good health outcomes. So I think I'm not sure if there's like a one prioritized agenda, but I think all of us in our different ways are prioritizing the need for expansion of technology and really even expansion of the ability for patients to have access to like the technology itself, like not only like internet, but like a computer or a smartphone, or having tech literacy in technology to be able to understand how to use these things. I think all those things are really important. So it is going to take a multi-pronged approach to be able to tackle the issue. But obviously this panel is so energizing this morning. So I have no doubt that we're all on the case.
Yeah, I would say I totally agree with that. I think it comes down to where can we start, right? Where is the need the greatest? And what's the domino effect, right? If we get one thing right, what is that one thing that we need to get right that's going to tip everything else? And I think that it comes down to the communities that are most impacted, right? And in this case, with maternal mortality, it's crystal clear, right? If we can improve care for women of color in the US, it's going to change care for everybody. It's going to have a domino effect. So I think that technologies that can enable that care are going to be the ones that, at least from my perspective, are going to and are really the focus of conversations. And if we think about it, we go 3 layers deep, right? Where are those women? Well, 40% of pregnant women are Medicaid moms. A disproportionate number of those moms are women of color, and a disproportionate number of them have comorbidities. And comorbidities means you're an at-risk mom. And if we kind of keep walking down that train of logic, from a technology perspective, it becomes pretty clear what is going to help the most, right? Because we get very specific. So again, you guys know I could go on for days and I won't go into detail, but I think it really comes down to what is going to drive the most impact. And I think the community remote monitoring, bias blind algorithms, those are some of the aspects I think are most key.
Totally agree. I think if there's any kind of takeaway, because I keep hearing it, right, repeated amongst all of us, is that when we're talking about the integration of healthcare and technology, we have a responsibility to make sure that technology is not further exacerbating any health inequalities, right? And so I think keeping attention to that has got to be so important. And I'm again so thrilled to be hearing us echoing all of the same sentiment in that regard.
And the only thing I would ask, I think Veronica broke everything down so expertly with the stats and what we should be doing, from the implicit bias training to the home care programs. Is that that's exactly, I think, where the administration is focused with its investments in $200 million in its budget and the $30 million for the home care programs and implicit bias. So I think that's right. And not to mention, again, the $100 billion in broadband. It's taking the data that we know thus far and then and taking, you know, where we think the solutions will have the most impact, and then really just investing resources and energy and attention and prioritization to those solutions that we think will bring about the most impact and ultimately just reduce the maternal mortality and morbidity rates.
So I'd like to address this question that has been posted. Can the panel speak to the intersectionality of the rise of Black women power in the historical leadership of strength and stigma? So one of the things about this question, it asks towards the end, and I think this is speaking towards the work that's being done around maternal mortality, is should we own up to this demonstrated strength and how to best apply it today to new opportunities for saving ourselves? So as someone who is an interdisciplinary researcher, who understands that intersectionality came out of the work of critical race theory, who uses critical race feminism in her work and her advocacy and understands the work of Kimberly Crenshaw, I will say this. The question of whether or not Black women have a legacy of strength, we're not questioning Black women's specifically strength or abilities or capacities. We're questioning why the environments are so inequitable that we have to persevere and push through them. It's not that we're strong. It's not that we are strong. There's no question of this idea and concept of strength. It's that oftentimes the strength that that society expects of us is strength to push through an equitable environment. So rather than requiring Black women to save ourselves, which we do because we have to, we should be questioning the environments that are requiring us to constantly advocate for ourselves versus supporting our wellness. So that's why a lot of the mental health advocacy work we do, we do advocate for increasing access to care. We do advocate for the training of licensed mental health professionals in regards to culturally responsive mental health care. But there's also a social justice and equity aspect to our advocacy that says we need to have equitable healthcare systems, education systems, criminal justice systems, food access, what have you. We need to create environments that foster our mental well-being versus hinders them. So, in regards to speaking to intersectionality and Black women's power, that's there, and we're not questioning that. And we know that is what it is because of what we know from feminist work, from Black critical race feminism, from Black female feminist thought. We already know those things exist, and we know that it is a part of our even African diasporic understandings of self. We get that. What we are saying is that there's systems of inequity that give rise to the health disparities that are embedded in the social determinants of health that we are addressing, that we've addressed quite a bit in this call, that are the reasons why mortality, infant mortality rates are so high, and why there's such a difficult issue in regards to maternal health. It's why these things are happening. So will Black women continue to organize around these things? I'm sure. But I wanted to say that because when I saw that question, it's like, yes, intersectionality, but intersectionality also says we can acknowledge who we are while acknowledging where we are and addressing those things that are creating environments that are not serving us. And then I'll put it out to the panel.
I mean, yes to everything that you just said. I think for me as, a clinician right now, I think the thing that really continues to drive my passion is the fact that we're actually finally in the healthcare system and in medicine kind of taking care of our own house and taking care of how we have contributed to the poor health outcomes for people of color, for Black and Brown communities. And I think, when I was in medical school, a risk factor would be race, but we know it's not race, it's actually racism. It's implicit bias, it's stereotypes, it's the healthcare providers and the biases that they have, and how that affects who gets treated in certain ways, who gets certain tests, who gets even considered for certain diagnoses. And I think for me, that's it's, I guess I can say, reassuring in a way that medicine is actually finally acknowledging that it is systemic racism. There is systemic racism in medicine. There are biases that the healthcare providers and the system, have that contribute to why our communities do poorly. And it's not a genetic reason. It's not our fault, right? And so I think that is a game changer as we move forward in trying to dismantle those systems and to improve health outcomes. So
yeah, Rachel, I just want to add one specific example just to back up what you're saying is pain score, right? That's one of the areas that's been so well documented that, if two people report the same level of pain, a woman of color's pain is not going to be recognized, as at the same level. And I think that's a huge one, right? Especially as you're going into, C-section or you're in labor. I mean, it's, or afterwards, there's something happening to you and you're trying to tell someone, and if hopefully bias will get us, bias training will get us there. But I think even there, sometimes I hope that we'll get there faster with technology, like blood tests with biomarkers that can provide an objective measurement. Now that's a bit, Star Wars or something like that. But yeah, hopefully we can get there.
Okay, no, please go ahead.
I was just going to say, the only thing I would add is I feel like Rachel's saying yes to everything. When I think when this administration started, I mentioned the executive order on racial equity, and it's just that it's taking a whole of government approach, because it's not just, we're talking about maternal mortality, we're not just talking about like systemic racism and implicit bias in the healthcare system. We're talking about it broadly. We're talking about it across government, across various societal aspects. And I think one of the things that is important in this moment is that people are recognizing that at high levels. And I think that is the start to really being able to actually address it and make some strides in not just the area of health and maternal mortality, but across the board.
Hey, well, we are running out of time, even though I'd love to continue this conversation. I've really enjoyed it. And we do have a few more questions that have popped up that we're not going to have the time to respond to. What I'd like to do is just thank each of you for being a part of this panel and ask that you just give a closing statement just in regards to the work that you'd like to continue to do, or how people might be able to follow the work that you're involved in. We'll start with Rachel. You're muted again.
Literally the third time today that I've done that. I apologize. No, I really wanted to thank NMQF for helping us or giving us the platform to look at maternal mortality through a different lens. I think it's such a complex issue, as we've obviously talked about. We're peeling back layers today, and there's so many more layers that need to be addressed. And I just think I'm very, I'm very hopeful as we move forward. I think all of these collaborations, working with tech, digital partners and technology, policy, healthcare providers, researchers, I think that is what will get us out of this crisis. And it obviously is a huge crisis that has existed for years, and it has been a long time coming that we put the effort behind dealing with this issue. So I just really thank you for the opportunity today.
Thank you. Nikole?
Yeah, I'd just say, maternal mental health needs are great. We've seen exacerbation of the kinds of conditions that can really take a toll on the lives of mothers generally. And just attention to this fact, right? It's not going anywhere. I think we're in a new world in terms of the kinds of adjustments and mental health needs that we're seeing. And I just appreciate, again, being part of this discussion and continuing to keep focus on it, because that's where we're going to really invoke real change. So thank you so much for having me.
Thank you. Veronica?
Yeah, I just want to say thank you to everyone as well. I think this is such a meaningful initiative. And, from my perspective, it's going to take an ecosystem to change this. And, anything that I can do to support, please just call on me, anyone, listening, or this panel. I think, particularly, I think legislation and the agencies, like you said, Deanne, are really going to be moving the needle here, and it's going to take, an ecosystem change management, technology stakeholders, and so forth. So anything I can do, please just let me know.
Deanne?
Yeah, I just want to thank you all for being on the panel and letting me be a part of it. I learned so much from you all the panelists. Like, I am excited to take all of this stuff back to my colleagues, and I think that is ultimately my closing thought is the president and the vice president, they have echoed this time and again when talking in this space, in recognition that oftentimes women are not heard and they're not believed, that this is a space where they will be heard and they will be believed. And so I am eager to work with you all, with everyone on this issue. And I know the administration will remain a priority and a focus throughout their time here.
Thank you. So thank you again to all of our panelists. Thank you to all of our participants who tuned in for today's discussion. Know that this is just the beginning. Some of the questions that we weren't able to answer in the chat box spoke towards supporting mothers who may be managing HIV. It spoke towards teen pregnancies and policy around health education. It spoke to additional guidelines in regards to technology, and even spoke to the role of men and fathers and husbands in regards to maternal mortality and health. So this is just a beginning. This is the surface. I'd like to thank the National Minority Quality Forum for always bringing together such a wonderful group of individuals and keeping these conversations at the forefront. So we encourage you to attend and enjoy the rest of the summit today. And if you'd like to stay in touch with No More Martyrs, you can find us at nomoremartyrs.org. Thank you again to the National Minority Quality Forum, and everyone have a phenomenal day. Thank you.
Thank you
so much.